start first by saying that very big thanks to all these senior teachers and committee members of IOA for giving me this opportunity. It's a privilege to be among the stalwarts, and I just seek their support to make this presentation a success. So this is a long case of scoliosis, history examination and management for postgraduates. So scoliosis in exams be like this, where you think that you are a deer and you're being hunted down by a tiger. But actually, if you have prepared well for scoliosis, you will end up knowing more than the examiner in 95% of cases. It's because it is blessing in disguise. It's reliable and reproducible findings. It has easy special tests. And if you use the right adjectives in diagnosis, you just nail the case. Now, scoliosis is a presentation. It's not a diagnosis. All these are scoliosis, but to say it's a scoliosis case is actually insufficient and you need more. What we want to know about scoliosis in clinical examination and history is, first of all, uncover the etiology, whether it's idiopathic or non-idiopathic. Where does the patient lie in its skeletal maturation chart? Is the patient pre-pubertal, post-pubertal? What are the patient complaints? Why is he coming to your clinic? Is it for cosmesis? Is it because of respiratory difficulty? Is it sitting imbalance? Or is the caregiver concerns from the parents? And when you decipher all these, you get to the management. Now, history and examination is important to remember the goals. A patient comes to you with scoliosis. Now you have to describe the scoliotic deformity through correct adjectives. You have to uncover the non-idiopathic causes of scoliosis. You have to comment on growth maturation. Where does the patient lie in the growth chart? How far he or she is away from the pre-growth velocity? Or actually has the patient crossed the stage of peak growth velocity and achieved skeletal maturity? Then demonstrate a structured pattern of history taking and examination, and finally make a complete clinical diagnosis. Now, it's useless for me to talk about history and examination unless I touch upon the pathology of scoliosis. To come on to that, for a postgraduate, just remember that scoliosis is lateral curvature of the spine more than 10 degrees. True structural scoliosis is a three-dimensional deformity. The axial rotation of the vertebra creates the rib hump. This is because when it rotates to one side, the ribs get crowded on the side of convexity and it creates a hump. And because it actually alters the entire chest wall, you have an anterior rib hump contralateral to the side of the rib hump posteriorly. A lateral shift in the coronal plane creates the surface curvature, and this also in turn also creates uneven shoulders. Now also know about what is compensated and what is uncompensated scoliosis. In compensated scoliosis, a major curve is balanced by a minor curve so that the head falls directly on the sacrum. In uncompensated scoliosis, the head falls away from the sacrum. These tend to be more severe and more symptomatic. It's also important to know that a scoliosis that starts before 10 years of age is early onset and has a different prognosis and treatment algorithm. A late onset scoliosis starts after 10 years of age. Idiopathic scoliosis occurs without any underlying trigger, whereas non-idiopathic scoliosis is secondary to a trigger like congenital, syndromic, neuromuscular, and even secondary non-structural curves. Here is a summary of non-idiopathic scoliosis etiology. Remember that in secondary non-structural curves, you have the sciatic scoliosis, you have the osteoid osteoma. The severe leg length discrepancy can also cause scoliosis. Pain-causing lesions or lower limb imbalance triggers scoliosis in these conditions. Now, the examination and the sequence of history taking remains the same. You start with history, you go on to the gait analysis, then you do inspection, palpation, measurements, neurological examination, special tests, and finally the diagnosis. And let me tell you, there are not many subheadings in these major headings, and that's why scoliosis is simple. To start with history taking, a good history taking should help you reach a narrow differential diagnosis. If your differential diagnosis is wide, probably you haven't taken a good history. The patient will always come to you with complaints of deformity or concerns regarding the shape of the back. They might put it as twisting of the back, humping of the back, uneven shoulders. Ask the patient specific questions. When was it noticed? Early onset is more progressive and is more likely to be non-idiopathic. Who noticed it? is the parent or the patient. This is important because if the patient notices it and comes to you, that means the cosmetic problem is paramount. Ask about the progression. Is it rapidly progressive? If it is rapidly progressive, it's likely to be non-idiopathic and it will require an early intervention. Ask about body image concerns. Concern over body image is prime indication for surgery in idiopathic scoliosis. Now, pain is not common in idiopathic scoliosis, although literature tells you that almost 1/3 of cases have pain, but the pain is mild. Severe unremitting pain, think about tumor, infection, spondylolisthesis, night pain, rest pain is highly suspicious. This calls for advanced imaging. Caregiver concerns of paramount importance in neuromuscular scoliosis patients. These patients generally have low IQ. They can't tell their complaints themselves. It is the parents who find it difficult to feed them, to take care of them, and that's why they come to you. These patients also suffer from functional quadriplegia. They're commonly paraplegic, and just to maintain a normal posture on a wheelchair, they have to use their both hands. That makes them quadriplegic. Ask about questions regarding cardio-respiratory compromise. Does the patient have breathing difficulty? Does he or she suffer from frequent chest infection or frequent hospitalizations? In big C-shaped curves of neuromuscular scoliosis in young patients, this is a common complaint. And it's been shown that correction of deformity reduces all these problems. Ask for weakness, sensory deficit, foot deformity, gait disturbance, and loss of balance are primary neurological symptoms with which the patient will come to you. If there is underlying neurological abnormality that has triggered scoliosis, ask for foot deformities. Pes cavus, flat foot, hammer toes are all seen with syndromic scoliosis and also underlying spinal dysraphism. Ask for associated history. Now, birth and developmental history is extremely important. Ask if there is a history of difficult and prolonged labor, delayed milestones. Is there difficulty that child finds keeping up with the peers? Are there autistic traits? Are there learning disabilities? All these point toward syndromic scoliosis and neuromuscular scoliosis sometimes. Ask for a family history. Is there a scoliosis in the aunt maternal side or in siblings? Idiopathic scoliosis can be like that. Neurofibromatosis, Marfan's, all can run down the families. Ask for menarche status, change of voice. Now, this gives a rough idea as to where this child lies in his or her growth chart. Post-menarchal patients normally have crossed the pre-growth velocity and have entered a phase where they're close to skeletal maturity. Of course, this has to be confirmed with proper examination. Now, starting off with the examination, we start with the gait analysis. Ask the patient to straight walk, heel walk, toe walk, check for the Romberg sign. A Romberg sign will uncover any loss of balance that might be occurring because of underlying syringomelia or a spinal cord tumor. You start from the inspection. You start from inspection from the back, head to toe. Comment on the position of the head. Comment on the hairline. Low hairline is seen in clipple field deformity. Look at the level of shoulders. Look at the prominence of scapulae. Look at the lateral margins of the trunk. Are they asymmetrical? All these have to be noted down in the correct order. Now, curvature of the spine. Describe, use the right adjectives. Record what's the location of the curvature of the spine. Is it thoracic or it's lumbar? What is the major curve? Which is the largest curve? What is the side of convexity? A scoliosis is always named according to the side of convexity. Look at the contour. Is it smooth or angular? Angular scoliosis indicates underlying neural abnormality and has to be investigated with the MRI scan. What's the major curve? If it's a compensated scoliosis, there will always be a minor curve, but that again will be minor and will be less visible. Can you see a rib hump? Can you see a loin hump? Is there a step off? Spondylolisthesis sometimes itself can trigger scoliosis. In that case, those cases, many times you just need to fix the spondylolisthesis and scoliosis correct itself. Look for signs of spinal dysraphism. Is there a patch of hair or a dimple or a sinus? Coming on to inspection from the front, again, not many subheadings. You'll find prominence of the chest, which you expect contralateral to the side of the rib hump. Look at the costopelvic angles? Are there any ulcers there? Is there any area of redness? Because these become tender areas, and neuromuscular patients, because they can't complain for themselves, they cry or wince if you palpate them, which I will mention later on. Look at the position of the anterior superior iliac spine. Fixed pelvic obliquity is very commonly seen in neuromuscular scoliosis and should be recorded. Finally, especially from the side, again, excessive lordosis, kyphosis, kyphoscoliosis, lordoscoliosis are very commonly seen in syndromic and neuromuscular patients. Look at the foot, asymmetric foot size, high arch foot, flat foot, hammer toes. They, especially in combination with sensory abnormalities and absent abdominal reflexes, indicate underlying syringomyelia or a neural tube defect. Look at the skin. Are there caffeole spots? Is there any axillary freckling? Noted down. Coming on to palpation, look for tenderness. Now, it's very uncommon to find midline tenderness in patients with idiopathic scoliosis. If you find it, think about a vertebral tumor, like osteoidostoma or osteochondroma. Tenderness can be commonly seen over a big rib hump. That's more because of a muscle imbalance, and it generally tends to be mild. Look for costopelvic tenderness. Again, in neuromuscular cases, in very narrow costopelvic angles, you might even find an ulcer. And this might be very tender, and the patient will start wincing. Although he may not speak anything, because these are patients of neuromuscular scoliosis, they can't express themselves that well. Always don't forget to measure limb length, and a limb length discrepancy itself can create a scoliosis. If you prescribe a simple shoe raise, that corrects the deformity. Now, compensated versus uncompensated scoliosis, you need a plumb line. Drop the plumb line from the inion. If not the inion, then from the C7 vertebra, which is the most prominent vertebra, and see where the plumb line drops. If it falls within the ambit of sacrum, this is a compensated scoliosis. If it falls away from it, then that's uncompensated scoliosis. Now, this is a very important test that needs to be done in order to quantify and also to achieve a few objectives. You need a scoliometer for that. It should ideally be provided. If you can buy it, take it to the exam yourself. It makes the rib hump conspicuous. Ask the patient to fold both the hands and bend forwards. An examiner looks at the patient from the side and behind. A hump becomes visible if it is in the thoracic area, and record it as a rib hump. Now, if you see a loin hump, don't call it a rib hump, please. The loin hump is because of a lumbar scoliosis, and it's present much more distally down. Record the scoliometer measurement. Ideally, when the patient is bending forwards, put your scoliometer right at the top and slightly with its hemisphere right on the furrow. Just slide it up the summit. At the summit, record the scoliometer reading. Here it is a little more than 11 degrees. Record it. This is the size of the rib hump clinically. Similarly, you can measure the size of the loin hump. Addison forward bending test will also help you differentiate between non-structural and structural scoliosis. For example, a patient with a sciatic list, if he is able to bend forwards, it should disappear. Similarly, other causes of non-structural scoliosis should disappear the curve when the patient is bending forwards. Now, flexibility is also very, very important. You have to comment on the flexibility because this will decide your further management. A very rigid curve is more likely to be non-idiopathic. If the child is small, you can just hold him up, suspend him in the air, and as you can see here, the curve will just disappear. Another way to test for flexibility is the push-prone test. You place your arm over the rib hump and do a counter by placing your other hand on the iliac crest. And if you can correct the deformity, then this is a flexible curve. Also, don't forget to look for signs of hyperflexibility. Marfanoid habitus, Marfan syndrome, Ehlers-Danlos syndrome, all are associated with scoliosis and they have different prognosis. Beighton score more than 5/9. There are 5 things need to be done and each is given a score. If the score is more than 5/9, this is definitely hyperlax individual. Look for high arched palate. Measure the arm span and measure the height. If arm span is more than the height, this indicates a Marfanoid habitus. You have to comment on that. Now, coming on to the neurological examination, this has been covered very thoroughly in the previous lectures. Go through motor examination, sensory examination, reflexes. I want to make a special point about the abdominal reflexes. Frequently, it is the only finding of underlying serious neurological pathology, and absent abdominal reflex may indicate underlying cerebromalia. Don't forget to test planters as well. Height measurement. Now, it's important in scoliosis because in early onset cases, the sitting height reflects the truncal growth. And if serial sitting heights do not increase while the curve increases, this indicates that there is a need for intervention. The spine is growing sideways rather than vertically, and then sooner or later, this patient will come back to you with breathing difficulty. Now, assessment of growth is another very, very important aspect of examination. All scoliosis types progress with growth spurt. And any patient that enters your clinic, you have to, through your clinical examination, find out whether this patient is still waiting for his peak growth velocity, or is he past his peak growth velocity? Has he actually achieved skeletal maturity? And that's why it's good to know about the Tanner staging. Most of the time, peak growth velocity happens between Tanner stage 2 and 3. And if you are able to detect a patient who is Tanner stage 2 and let's say has a 50-degree scoliosis, you should be able to prognosticate and tell the parents that this is very likely to progress to potentially 70 or 80-degree curve. And that's where there is the ideal window of opportunity that you can do some intervention, either bracing or preferably surgery. So again, know the Tanner staging. Know what is Tanner staging for boys. Know what is Tanner staging for females. Always ensure you have a female chaperone to help you perform Tanner staging. It is also advisable for the female chaperone alone to make all the observations, and I think that will be acceptable, especially in with the type of society and cultural values that we live in. Now, at this point of time, it's not the clinical part, but I'd like to touch upon the radiological assessment of growth. We frequently talk about razor sign. We have frequently talked about fused triradiate cartilage. Please understand that a razor sign stage 1 appears after peak growth velocity, and a razor sign stage 0 means that peak growth velocity is still away, but we can't really predict how far away it is. And a stage 5 is obviously skeletally mature. So if a patient presents you with a razor sign stage 1, is all probability this curve is not likely to progress. Also comment on the triradiate cartilage. Fused triradiate cartilage indicates skeletal maturity. They're both not good in predicting peak growth velocity. Standard staging is the most accurate, but it's complex. Again, it's a radiological thing. It's not part of the clinical examination, but the questions might be asked from you regarding this. Now, remember the red flags. Non-idiopathic scoliosis markers, early onset, rapid progression, severe unremitting pain, delayed milestones, difficult labor, weakness, gait disturbance, left-sided curves, sharp angular curves, foot deformity. If you find any of these, become alert. You're dealing with a potentially non-idiopathic cause of scoliosis. Now, keep it simple. When you make a diagnosis of scoliosis, you're summarizing all what is important for creating a logical management plan. So in your diagnosis, mention age, sex, mention what side the deformity is, mention the onset, mention the location. The curve with the greatest scoliometer reading should be mentioned first. Comment on the flexibility, whether it is compensated scoliosis or uncompensated scoliosis. Where does the patient lie with respect to the level of maturation? And finally, mention about neurological deficit and pathology. If there is no neurological deficit, mention it. I'll give you case examples. Now, this is the idiopathic scoliosis in a 60-year-old male with normal neurological examination. Now, how should you make a diagnosis? You have to include all those points, use the right adjectives, and make it structured. So you say, 6-year-old male patient with a left-sided, thoracic, flexible, compensated, early onset, probable idiopathic scoliosis with no neurological deficit. So I think it's better to add probable because sometimes you find surprises when you do advanced scans. The second example is idiopathic scoliosis in a 12-year-old girl with no neurological deficit. You say 12-year-old pre-pubertal girl with right-sided, thoracic, flexible, compensated, late onset, probable idiopathic scoliosis with no neurological deficit. This is a third example of a patient, 15-year-old girl who presents to you with skin pigmentation and scoliosis. It's not difficult to understand that these are cafe or spots. So you're dealing with the case of neurofibromatosis. How will you put it? You can say 15-year-old post-menarchal girl with left-sided, thoracic, rigid, uncompensated, late onset, non-idiopathic scoliosis secondary to neurofibromatosis. Now, the management perspective for a postgraduate, I will not go into the details, but I will just talk about what should stimulate you clinically to make a management plan. Now, this is the slide. I like to revise it. So entire management revolves around the interplay of the etiology, skeletal maturation, and what does the patient come to you for. Together, you decide the management. The management can be discharge from the clinic, serial observation, bracing, or surgery. In our country, bracing may or may not be feasible, but still an option. Now, remember this one line: a curve that causes significant symptoms and or is likely to progress requires some intervention. To talk about this first case, she's a 17-year-old post-menarchal girl with right-sided, thoracic, flexible, compensated, late-onset idiopathic scoliosis with no neurology. We know she's skeletally mature because she's post-menarchal. We know she's skeletally mature also because she has fused radiate cartilage, so there is no risk of significant progression. If this patient says, I have no cosmetic concerns, I'm happy with the way I look, I'll say, okay, go home, discharge, you don't need anything. But if this patient says that I don't like the way I look, then option would be, of course, to operate. So here the patient's complaints are dictating the management. Let's talk about another case. This is a 60-year-old male patient with a left-sided, thoracic, flexible, compensated, early onset, probable idiopathic scoliosis and no neurological deficit. It's a 45-degree curve, and there is significant growth of the trunk left. This curve is likely to progress. But can you fuse it? Now, this patient is too young for fusion because he hasn't still achieved the truncal height required for normal growth of the lungs and normal breathing later on in the life. So what you can do is do a trial of bracing. If it works, controls the deformity, well and good. If not, then do a growth sparing surgery. Now, this is the case 3. This is a patient, 12-year-old patient, prepubertal, male patient, right-sided, thoracolumbar rigid, uncompensated, late onset neuromuscular scoliosis, which is secondary to cerebral palsy. These patients will have multiple issues. They will have gastroesophageal reflux. These patients will have a bad chest condition, recurrent hospitalizations, low mentation, high risk for infection. And here, the decision to operate lies with the parents. The parents feel that they find it difficulty to feed the patient is not able to do proper wheelchair sitting. It's affecting their quality of life and patient's quality of life. Of course, not known to the patient, but it does affect it. In that case, you have to operate with parental consent. Now, again, certain management perspectives for a postgraduate. We'll talk about the preoperative imaging, what minimum preoperative imaging you require. Now, indications for MRI, all patients with red flags should get an MRI scan done to rule out neurological problems like spinal bifida, spinal myelomeningocele, other types of spinal dystrophism like diastematomyelia, syringomyelia, etc. Do full spine standing radiographs, AP and lateral, so that you know what curves you're dealing with. This will also be important for your pre-op planning. Do side bending films, again for flexibility. This is the least you have to tell to the examiner regarding the pre-operative imaging. Also, you should know about Mehta angle and phase of rib. Now, examiners are very, very fond of asking what Mehta angle is, what phase of the rib is, because these have been known for a long time and they do have a bearing on the prognosis. So Mehta angle is an angle that is made between a line that is perpendicular to the end plate of the apical vertebra and a line along the rib head and the neck. The angle on the concave side minus the angle on the convex side. If it is more than 20 degrees, that's likely to progress. The original paper was done only for infantile scoliosis, but it's not uncommon for people to ask these questions even for early onset scoliosis. Again, a phase 2 rib. A phase 2 rib is a rib which is overriding the apical vertebra on the convex side. Now, this indicates progression. If it is not overriding, this is phase 1 rib, and this is likely to resolve. So remember these. Now, management perspective, again, for a postgraduate student, we're not talking hi-fi stuff, we're talking about basic stuff, and this is what the examiner will expect out of you. The definitive surgery for scoliosis is a fusion surgery. It can be either posterior or anterior. Nowadays, the trend is more towards doing posterior surgery. The goal is to achieve a well-balanced, a stable, and fused spine after maximum possible correction within safety limits. So 100% correction is never the aim. We have to do the correction, but within safety limits, and achieve a fused spine, which is stable and well-balanced. It is performed only after the patient has achieved a minimum T1 to T12 height of 20 centimeters, which is required for adequate lung function. In early onset scoliosis, when T1 to T12 height is less than 20 centimeters, to allow the spine to grow. You can try bracing initially. If that doesn't work, you do growth sparing options. Growing rods, magic rods, trolleys are the different options that are available. This will allow the spine to grow, but at the same time, it will control the deformity so that things don't go out of control. And once you have achieved adequate T1, T12 height, you go for definitive fusion. So the take-home message is, just remember the goals, do a structured examination, demonstrate to the examiner that you understand the pathology and that you are able to describe the pathology, know about when to do advanced imaging, know about what management options are available and what dictates the management.